Okay, let's finish her raw. 4.7, Disseminated Diseases, the end of the unit. If I sound a little peeved, I just recorded this and it didn't save, so that's really wonderful stuff. Let's go. Lymphedema, so automatically kind of a misnomer, not really a disease, kind of a symptom of diseases, but we'll get into it. It's okay. So this is a chronic accumulation of interstitial lymphatic fluid due to impaired drainage. Okay, this comes in two flavors, primary and secondary. Primary is more so congenital, so you're born with this. You're born with a malformed lymphatic system to some degree. Okay, not really what we're talking about today, more so secondary lymphedema arising after infection, surgery, or trauma. And we'll get into a couple of those cases in just a moment. So normally, the lymphatic system collects fluid, proteins, and immune cells from tissues and then returns them to circulation via the thoracic or right lymphatic duct. So think of that drainage, right? Our legs, our arms, and our head. That is the drainage pathway. Ultimately, all the lymph is going into the right lymphatic or the thoracic duct. That's what should be happening. In this case, we have some sort of blockage preventing that from occurring correctly. So the lymph stagnates, it pools. Any stagnation in most biological mechanisms is not good, right? A stagnant pond grows mosquito larvae, and if you are too sedentary, right, that's bad for your muscle and cardiovascular health. So stagnation in general, not good. Same in the lymph. We get protein-rich fluid buildup. Furthermore, we get the stasis promotes inflammation, fibrosis, and dysfunction. Okay, so all around good, not good. We don't have turnover. We don't have the removal of these inflammatory compounds. Instead, we get the pooling of inflammatory compounds. Furthermore, we get recurrent infections due to poor trafficking. So my immune cells can't move to the degree that they are usually capable of moving. Antigen presentation gets stymied. It's a whole mess. Yeah, so your neutrophils and macrophages can't do their job because they just keep getting called to this area that they can't leave. So that's kind of how it looks. We got normal, less normal, less normal, super less normal. So this is a case of lower limb lymphedema where the fluid just cannot get back home. It just pools in this compartment. Lower limb is a typical spot for this because of gravity. All right. So again, what's the failure here? Well, the lymph flow is not flowing, so that stymies antigen presentation. My dendritic cells can't flow properly. They can't get to the lymph nodes to produce an antigen presentation response to the B and T cells, so my adaptive immunity is very much weakened. Furthermore, the local inflammation recruits more innate cells to the area that end up getting stuck. Their clearance is poor because the drain is completely clogged. All right, so put those together, that equals an increased risk for chronic infection. I'm not producing any adaptive cells or an adaptive response to the potential pathologies in the area because I can't do antigen presentation, and the local inflammation is just making the innate response a whole mess. Maybe I'm getting some good inflammatory signals to help with infection, but I'm not getting any good clearance of any cleared compounds. So it's just a hot mess and increases that risk for a bad infection. What are some common causes? So two big causes. We have filariasis, which is a nematode infection. For whatever reason, these nematodes are perfect size to drop into the lymphatic capillary bed and work their way up into a lymph node where they get stuck because that's not an empty tube, right? There's a whole sieve there where the filtration is happening. Now, eventually, that nematode is degraded and killed, but due to how the inflammation process works and how the recovery process works, we usually have some fibrosis accompanying that resolution of inflammation. Due to the nematode being the size of the lymph node, we have too much fibrosis, and that can cause a big clog, right? The fibrosis is just a bunch of collagen fibers. So now I don't have a good amount of flow passing through the lymph node. I have a blockage, so anything north of that blockage, well, it's gonna pool in that area. So that's a common weird cause. And then another common cause, which makes me think I should have had a lymphedema talk first rather than the lymphoma talk first, but that's fine. We have cancer malignancies or lymphomas. So those, remember, are discrete masses. These are big tumorogenic clumps. That mass can absolutely block potential drainage. Furthermore, let's say we have the mass, we have detected the mass. Remember, the cervical region was the most common part that could be that a mass usually generates. And let's say the provider was able to say, okay, I can get rid of this mass. I can perform an excision. Well, sometimes those lymphatic vessels are very delicate, right? They're very, very thin-walled. Maybe the surgeon knocks out a couple more than he thought he was going to, or she. My bad. But we might have issues post-excision, okay? So that's not good. We went in to get rid of the cancerous mass, but now the patient comes back and their whole left arm is all swollen up, well, because I knocked out a bunch of potential drainage paths that the arm was using when I took out the lymph node. So those are two ways that a lymphoma can cause some lymphedema. Okay, so yeah, that is the overview of lymphedema, just that pooling of fluid due to infection, surgery, or trauma. All right, next up is a serum sickness. So this is definitely on brand for this unit because we talked all about allergies and hypersensitivities. Now, allergies, as we commonly know them, are the type 1 allergies, IgE mediated. That is a bit different from this being the type 3 hypersensitivity reaction. These are triggered by circulating immune complexes. What is an immune complex? It's an antigen bound to an antibody. So I have my big old antibodies down here. Let's say in this case, the antibody has tagged these little nugget antigens. They're usually a bit bigger than this, but that's fine for this drawing's purpose. So now the antigen and the antibody are tagged. They are one with one another, so we call that the antigen-antibody complex. You have large amounts of, or in the case of a serum sickness, you would have large amounts of soluble antigens floating around in the bloodstream. This could be foreign serum proteins, drugs, or antitoxins, and you eventually get an antibody to tag to that protein, to that drug, to whatever that has been administered. So let's walk through that sequence. Antigen enters the bloodstream. Okay, pretty common. Body makes an antibody that binds that antigen. Business as usual. So you have a diffuse binding of an antigen to, or the antibody binding to that antigen. So you have these antigen-antibody complexes everywhere. So those antigen-antibody complexes are so heavily concentrated that it actually becomes a pathology. We start to circulate so much that they deposit in the vessel walls, in the glomeruli, which are parts of the cells of my kidney, and in the joints, all spaces and all structures where I don't need antibody-antigen complexes digging into that tissue, right? The antigen, the whole point of the antibody is to tag something for deletion. It's to alert the complement system that this needs to get tagged for deletion. I don't need to tag my vessel wall. I don't need to tag my glomeruli. That's going to cause inflammation in an area that I don't need it. Okay, this is, in the case of the joints, this is where rheumatoid arthritis comes in, except we also have an autoimmune component going on to that as well. So a very damaging sort of hypersensitivity here. Again, that complement activation due to this antigen-antibody complex that recruits this, which recruits neutrophils, which means, more enzymes and more reactive oxygen species. So the ROS idea has come up a lot. And there's a lot to be said about oxidative stress being very, very detrimental to our normal health and machinery And there's a lot of theories about that being the leading cause of aging in general. All right, so that will lead to that local tissue injury causing some damage. So let's go back. Why would I ever have a bunch of foreign serum proteins or drugs or antitoxins floating around in my system? Good question. So you can have treatments for diseases that include injection with foreign serum proteins. One of which, a great example, is monoclonal antibodies. Okay, you can be injected with monoclonal antibodies, which are just grown antibodies built and bred to tag whatever you need to get rid of. That could be a bunch of things, right? It depends on whatever pathology we're fighting. It could be a cytokine, right? One of the cellular signals they might be secreting too much of. It could be that you create a cell the wrong way. You might have something wrong with one of the, cellular signals that causes whatever one of your cells to be formed. You know what I'm trying to say. You might be forming something incorrectly, so we need to get rid of that stimulus. Okay? So those are called biologics. I know I did not write that very well. Let's try that again. How about biologics? Heck yeah. So those are drugs that use some sort of biological mechanism to get their effect across. When there are monoclonal antibodies, it usually ends, or it ends in an A-B ending. Okay? So the greatest example, because I see this absolutely everywhere, is Skyrizi. That is a monoclonal antibody used to decrease the level of IL-23 in serum. And you're like, hey man, that doesn't end in AB. Skyrizi is its marketing name. Its real drug name does indeed end in AB. So, in folks that are prescribed Skyrizi, they have their physician has come to the conclusion they probably have too much IL-23 floating around in serum, so I'm going to give you an antibody that tags IL-23 and removes some of that from circulation, and hopefully that stops whatever disease, whatever pathology that you're experiencing. That's the whole idea behind it. Now, I don't know what the risks are at all for Skyrizi or any monoclonal antibodies for that matter. But there is the likelihood, there is some sort of potential that, that monoclonal antibody is not from you. You aren't making that naturally. You are being prescribed it and injecting that. That's all well and good, but that's not you. So you do run the risk of having something called serum sickness, where the body ends up recognizing that administered antibody as foreign. All right? So we create antibodies that bind that antigen, creating these complexes that are everywhere because it was injected into the blood, so that stimulus is everywhere, so we're creating antibodies for that thing everywhere. And in this case, in the Skyrizi case, or in any type of monoclonal antibody case, you'd be creating antibodies for antibodies. Just antibodies that you didn't make. Antibodies that were prescribed to you. Yeah. Very cyclical, kind of confusing, but the main takeaway here is that you just have antigen-antibody complexes all over the body, all around, all in the serum, and just causing havoc. If there's too many of them, they increase their concentration so much so that they deposit in the vessels, deposit in the kidneys, and that's not good for anybody. Furthermore, they activate the complement pathway like crazy. That's just what antigen-antibody complexes do. Now I have hypocomplementemia. I've activated my complement pathway so much that I just don't have any of my complement proteins, or not nearly as much as I should. So, if a bacterial infection occurs, and I want the complement activation to occur, which is like all those C1 to C9 proteins that eventually form the membrane attack complex, that membrane attack complex punches a hole in those bacterial cell walls. Really, really helpful for that innate pathogen defense. But if I'm using up my complement proteins around the entire body, well, I'm not going to have that defense anymore. So, yeah, very detrimental. All right, so that's serum sickness. That is a type 3 hypersensitivity. That is going to come up again. So, make sure you understand it. And if you don't, shoot me an email. Last but not least, we have disseminated fungal infections. Okay, so this is kind of one of the avenues of of sepsis, albeit much more rare. Bacteria sepsis is obviously the most prevalent. Viremia can eventually lead to sepsis, and to a lesser extent, we can have this fungal infection. And you'll see why it's to a lesser extent just in a moment here. But I wanted to explore a less talked about avenue. So what is this? Well, it's exactly what it sounds like. Systemic fungal infection by Candida, Aspergillus, or Cryptococcus. Candida being the most prevalent. Spreads beyond the barriers into the bloodstream and the organs. Okay, so what happens in a healthy individual? Let's start there. Maybe a disrupted barrier, skin cracks, mucosal cracks, what have you. The defense here is primarily innate cells, so your neutrophils, your macrophages, and your dendritic cells. See, fungi are pretty large eukaryotes, so they have pretty robust cell walls. So they're poorly handled by antibodies and complement proteins. That membrane attack complex doesn't form as well. So we're really reliant on my innate cells. We really hope the recognition occurs well. What are we recognizing? We have beta-glucans and mannins. Mannins is a big fungal compound. These are conserved in that fungal kingdom, so we call those fungal PAMPs, fungal pathogen-associated molecular patterns. I'm not going to see these ever on human cells, so I know if I see those in me, that's got to be a problem. PAMPs activate pattern recognition receptors, which activate their effectors. That could be AMPs, that could be whatever this cell in question secretes. On the PERS on neutrophils end up secreting reactive oxygen species, enzymes, and causing the release of the nets. All right, so these neutrophils keep on popping up. Again, they're very helpful, but when they are diffuse and body-wide, not so much. But again, we want this neutrophil release because the reason that we never hear, or you don't hear as about fungal sepsis nearly as much, Candida gets absolutely slammed by your innate cells. It is only a disease, well, usually only a disease of the immunocompromised, of the neutropenic. So this is usually fought off quite easily in immunocompetent individuals. In immunocompromised folks, you might have decreased neutrophil activity. So those cells would struggle to prevent the infection from traveling into the bloodstream. And then we can potentially get that cascade of sepsis-like events where you have this disseminated vasodilation, disseminated vascular leakiness, leading to hypotension, leading to trying to get cardiac output up, only to realize that you can't because you're not getting any good venous return. So you have that disseminated drop in control of the cardiovasculature, just due to the fact that I have these inflammatory signals that are diffuse and body-wide. All right, again, it's no problem for the immunocompetent individuals, more so an issue for the immunocompromised. In bacterial sepsis, this can happen in immunocompetent individuals to a much greater rate than this. So that's why this is less talked about, rightfully so. Okay, so yeah, that is it. Those are the three big hallmarks that I wanted to discuss. If you're confused on any of those three, please do not hesitate to shoot me an email. And this is the last talk of Unit 4. So we have one more unit left, and then we're off to the races. It's been a pleasure. Let's finish strong. Thank you guys very much.